Multiple sclerosis is an autoimmune condition, so that means a disease where the immune system, instead of protecting against infections, actually attacks the body. And it is an autoimmune condition of the brain and the spinal cord, that's the central nervous system. There is probably stories of people that had MS from thousands of years ago, but definitely was described in the 1800s. So it's not a new condition. There was no treatment for MS until the 1990s. There were a couple of FDA-approved treatments for relapses, but there was nothing really for actually preventing new MS disease activity. So that's a new thing since the 1990s. So the first long-term treatment for MS was approved in 1993. Since then, we've had many more treatments that have been approved, and the field is still really growing and changing year by year. But it really is a recent phenomenon that we have treatments available for our patients. It's been thrilling to know that we have different options available now, even than when I started as a doctor. It really, in knowing that the patients' lives have been impacted in such a positive way, that's been a wonderful thing. For so many years, people have looked for that one cause of MS, but we have never found that there's one cause. And we really believe that it's probably a combination of factors that increases somebody's risk to get MS. And so among the factors, we can think of a few different things. Of course, people have always thought, is there an infection? Is this just a direct infection? We've never found that. People have looked at different viruses that may increase the risk and bacterial infections, but have never found that. There's not one gene that can really increase someone's risk for MS. There are people that have maybe a group of genes that together increase the risk, but there's not that one gene that people pass down. Of course, people have thought, is this something that is in the diet, that people are eating certain diets that might trigger the immune system to cause these attacks, but we have not found that. Research is ongoing in that area. One thing is that we do know is that smoking does slightly increase somebody's risk for getting MS. So that would be one cause, but that's again only part of increasing somebody's risk. So there is new research that's come out maybe in the last decade on the microbiome. Microbiome is actually trillions of bacteria that live in our bodies, and everybody has their own collection of those bacteria. And we're starting to think that people with MS may have a different types of microbiome than people that don't have MS, but that's really ongoing research. So what's really happening in the body of an MS patient is that the immune system, again, which is a collection of white blood cells whose real job is to protect from the outside, from bacteria, from viruses. What we think happens is that those white blood cells become confused and start to look at the central nervous system as an enemy for one reason or another. And so those white blood cells actually physically travel into the central nervous system, and they create these little areas of inflammation. Those are called lesions. And so a lot of patients with MS, they know that word lesion. That is a collection of these white blood cells that were attacking a certain part of the brain or spinal cord. And when they come in, they create this area of inflammation. It lasts for about 30 to 60 days in most people. After that, those white blood cells leave. We don't know why they come in, and we don't know why that they decide to leave. But in most patients, those lesions are not continually active. They instead become a scar. So there you can see it on the MRI. You can see there was an area where that attack did occur. But it's not an ongoing attack at that site. And that's where the word sclerosis comes from. Sclerosis means scar. Multiple sclerosis is not that rare of a condition. We have our most recent estimates were actually a long time ago that said about 400,000 people in the US had MS, but actually newer statistics are coming out that that number may be actually more than double that number. Yeah, so it's a lot of people, we don't know if the condition's becoming more common or if we're just better at diagnosing it at this point with our newer technology. We do know that it is more common for people to get MS away from the equator. And that's something that was first described in the 60s. And we think that might be related to sunlight and vitamin D. We do know that women get MS more than men, especially relapsing remitting MS is 3 times more common in women. And there's probably some explanations for that. And we do know that children also get MS, so that's something that's being more commonly recognized. The average age for MS patient to be diagnosed is really, I would say, about 20s to 50s. But you know, there are patients that are diagnosed both earlier and later than those ages. Now that we have MRI, thankfully, I think it gets misdiagnosed much less often. But every time we diagnose a patient, we have to be meticulous in thinking through what we call the differential diagnosis. That would be the list of other conditions that a person could have. And so we think about whether they could have a vitamin deficiency, whether they could have another autoimmune condition, whether they could have maybe a medication side effect or another toxicity. So there are other things that a patient can have, but I think it's been very fortunate now that we have MRI that we're much more accurate in our diagnosis. When we have a patient that comes in and has symptoms that could be consistent with MS, what we do is, first of all, we think about the MRI. And we get an MRI of the brain, and then there's 2 parts of the spinal cord we look at, the cervical and the thoracic spine. So sometimes that means a patient has to get a lot of MRIs in the beginning. We can use a spinal tap for certain patients to help us diagnose them. We don't get a spinal tap in everybody, and that's because MRI is very good at diagnosing, and so a lot of times we can avoid a spinal tap. The other thing is that a spinal tap is only positive 90% of the time in MS patients. There are 10% of people with definite MS, and their spinal tap is negative. And so that means we would put a patient through the procedure, we get a negative result, and we already know that they have MS. So we use it for certain situations where we're not sure, but we need more support for the diagnosis. So the most important thing always is to listen to the patient. And I really try to remember that, is that we do not use the MRI. We use it to diagnose patients, but we don't actually use it for prognosis. That's really important because we've seen that the number of lesions does not actually correlate to a patient's prognosis. So I use it to diagnose a patient, and then I move back towards the patient. I listen to them, I hear what they're telling me about their function, and I hear what they're telling me over time. I listen over time, and if the patient can walk the same distance, if the patient can do the same number of stairs, that's more meaningful to me than just looking at let's say an MRI that looks steady. But there are other things, mostly used in research, that can be used to try to quantify how a patient's doing. That would be, sometimes patients will ask me about the EDSS. The EDSS is a research scale that can help put a patient's MS experience into a number. And I think that's just a really hard thing to do, to take a patient's symptoms and put them into a number scale from 0 to 10. So we do that for the clinical trials, but in my office I wouldn't usually do that with a patient. I would just more listen to their symptoms that they have. We also have some other, even more detailed research scales that we would use for patients. A patient will often ask me what kind of MS I have. And a lot of people think that we can figure that out by looking at an MRI or looking at their examination. But actually it's what they're telling us. And so the different types of MS there's relapsing remitting MS, and then there's progressive forms of MS. And this correlates with the different MS disease processes. So the one that we've talked about so far is relapses or inflammation, and that goes with relapsing remitting MS. So a relapsing remitting MS patient would tell me that they are pretty steady from day to day. But then at some point they've developed new symptoms that worsen over days to weeks and then get better over days to weeks. And that would be a typical MS relapse. Where a person that has progressive MS, and there's a few different sorts of progressive MS, they have worsening that is just a little bit more steady over months to years. And when we look at a graph of the different sorts of MS, it's really a mix and a match of those two things. So there's people that have relapsing remitting MS, they don't have any worsening in between relapses. There's people with secondary progressive MS. They started out with relapsing remitting, but then they moved on to develop this gradual worsening over time. There's also patients that have primary progressive MS. Those people do not have any relapses, and what happens is just a slow worsening over time that just comes on slowly. There are patients that fall into the MS continuum, but they don't meet the full set of criteria. There's two of those examples specifically. One example would be called radiologically isolated syndrome. Radiologically isolated syndrome means that a patient is found to have on their MRI the lesions that are consistent with MS, but they got that MRI for a completely different reason. So say somebody just has an unrelated fall, or they're part of a study at a hospital, and somebody looks at their MRI and says, this looks like MS. So those patients, we call it radiologically isolated syndrome. Another thing I'll call it to patients is silent MS. And the reason why is because the patient never had any MS symptoms. Most typically, those patients are just monitored over time. If their MRIs change, or if they, of course, develop a symptom, we might treat them. But for the most part, we just watch their MRI and make sure that it's steady. There's another category of patients that do not meet the full set of MS criteria, and those patients are called clinically isolated syndrome patients, or CIS. CIS patients have had one symptom. So they might have an episode of optic neuritis, for instance, or numbness and tingling in their legs, but when we look at their MRI, there's only one lesion or a few lesions, and not enough to meet the full set of criteria to call them relapsing remitting MS. When we have a patient and we've diagnosed them with either having clinically isolated syndrome, relapsing remitting MS, or a progressive form of MS, we of course think about their symptoms, and we think about their preferences, and we think about what treatments are indicated for their form of MS. And most of our treatments are indicated for the relapsing forms of MS. That would be clinically isolated syndrome, which is a relapse. They've had a relapse, or the relapsing remitting MS patients. And most of our treatments are targeted towards those. We do have one treatment that also has been shown to work in primary progressive MS. So if a person has primary progressive MS, that treatment we would pick for them. A relapse is a new symptom that a patient has. Typically, they've never had that symptom before, and it is localized somewhere on their body. And that's important because sometimes we all just wake up and just feel a little bit blah, and that's not a relapse. A relapse is a lesion, in the brain or spinal cord that's causing this new symptom. And so, first of all, it's usually new, and then it lasts 24 hours. That's really important too, because a lot of times a patient might just sit a certain way or something and have a little numbness and tingling, but if they can shake it out, then that's not a relapse. So it's new, localized on the body, and lasts 24 hours. If we think that is occurring in a patient, then we bring them into the office and examine them. We don't have to treat every relapse. So a lot of times with a relapse, if a patient is functioning okay, say they just have a numbness in a leg, but they're walking okay, they're functioning in their life, we might just wait a few weeks because usually the relapse will go away. But if a patient's having problem functioning, say it's causing them to have problem seeing, or if their walking is not as steady, then we would give them a treatment, typically with steroids, over a few days. When we have a patient that we think needs a medication for MS, what I do is I talk to them about the goal of treatment. All right. It's interesting. Before we had many treatments out, we did not have a clearly defined goal, because if a patient had more disease activity, we did not have many more medications to turn to. So now, though we have so many medications in our toolbox, that we actually have defined a goal. It's called NEDA, no evidence of disease activity. So what I tell a patient is, this is you today. We're going to put you on a medication, and our goal is that from this point on, we do not see any signs of the MS continuing to be active. So that means no new lesions on your MRI, no new relapses, so you don't come back to me and tell me you're having new symptoms, and that your examination looks steady from visit to visit. I always tell patients I'm not tied actually to the treatment. I'm tied to the outcome. I want your MS to be steady. I don't want any new lesions or any new relapses. And I feel fortunate because in today's world, we actually can make that happen for most people. Shared decision-making is this idea that doctor and patient would decide together what the best treatment for that patient is. It shouldn't be all the doctor's decision, of course, what treatment that patient is going to be on, but we also don't want to leave it up to the patient, because the doctor does have the experience and expertise that could help with that decision. And so together, hopefully what would happen is doctor and patient sit down and decide what the best treatment option for that patient is. The goal of shared decision making is for the patient to completely understand what the benefits of the treatment would be, what the risks would be, what the side effects would be, and to make the best treatment possible going forward. It's really important to me that when a patient starts on an MS treatment, that they feel comfortable with the treatment that they're going to be on. I feel really passionate about that, because if a person's taking a treatment and they worry about it all the time, or if they're having bad side effects from that treatment, they're not going to want to be on their treatment, and they're not going to feel like that treatment's helping them. And so I think it's important to sit down with a patient. It really should be a second visit with a patient after the diagnosis is made, where doctor and patient sit together and talk about what the patient wants. I really respect a patient who tells me that they want to think about all their options. They want to think about going on to a treatment, or if they want to stay off a treatment. But I believe my job is to really give them a full view of the risks of not being on a treatment before they would make a decision not to be on a treatment. If left untreated, what we know from our studies is that most patients that had relapsing remitting MS did at some point develop secondary progressive MS. That was the majority of the patients before treatment. We think that's if the immune system, if it causes so many attacks, that at some point the brain and the spinal cord just become vulnerable to the progressive course. So we have a variety of treatments that are available for our patients, and there are different categories of treatments. There are injections. Those are our oldest treatments. I will call those the tried and true treatments for MS, and those have been around since the early 1990s. Most of those injections are a class of treatment called interferon, and then there is another treatment called glatiramer acetate, and the patient would take those treatments at home. That's a small injection, mostly under the skin. There's one that's in the muscle injection, and they would give those to themselves at home. And those are all indicated for relapsing remitting MS. We have pill options, and those are newer treatments that we have for patients, which is a great thing for patients. Again, they're taking those treatments at home, and again, those are indicated for relapsing remitting MS. And then we also have our targeted IV treatments that are antibody treatments. They're very direct treatments. Those are treatments that a patient would have to go to an infusion center, and they would get an IV drip of those treatments. There is a treatment that is a once-a-year treatment for 2 years in a row. There's a treatment that's once a month. It lasts for about an hour, that IV drip. And there's another one that is every 6 months. I think it's important to remember that just because we have different categories for MS, that doesn't mean that a person falls completely in one category versus another. the way that we make a diagnosis of a category is really based on what the patient's telling us. But we know that patients that have secondary progressive MS, they also still have the risk to have a relapse. And so most patients with secondary progressive MS, especially if they are relapsing, are continued on MS medications. The newest one is also indicated for primary progressive MS. That was a very big achievement for the field because that was our first treatment we had for primary progressive MS. We do think about with each patient what the best treatment for them would be. Some of our treatments are lower powered treatments. Those are probably our safer treatments, but they're lower powered. And we think about those for patients who maybe have a bit of a milder condition. And then we do have also treatments for relapsing remitting patients that have a more perhaps active or aggressive course. We have so many treatments for MS because researchers really have gone about trying to fix this problem in a lot of different ways. We do not treat a patient, I always say, based on like a cookbook recipe or something. We think about the patient, we think about what they presented with, how severe their symptoms were. We do look at their MRIs to think about their MS in that way. And what's most important is talking to the patient and seeing what is important to the patient. So that's one of the tricky things about MS being a condition of the nervous system, which really controls our experience in the world, is that when a patient looks at a list of symptoms, it can be quite long because it can be anything that we can experience. But it's really important to remember that most people do not experience that whole list of symptoms. But there are patients with MS that experience cognitive symptoms. That would be like word finding, or maybe they feel like their thoughts are a bit slowed. Some people with MS do struggle with anxiety or with depression. And then there's more physical symptoms. People do have visual issues, double vision. Some people have dizziness or balance issues, and then weakness, numbness, bowel and bladder issues, and then sexual dysfunction. I think that most patients with MS would say that they feel that a lot of their symptoms are invisible. When we have a neurological condition, it's something that the patient is feeling, but not necessarily something that their family or the doctor can see. And so I will often say that to a patient, that this sometimes is an invisible disease. But we know by listening to the patients what they're experiencing. Wellness is really important for MS patients. Because our disease-modifying treatments, they're preventative. So what they're going to do is they're going to stop a patient from feeling worse, but they're truly not going to help a patient feel better. And so that's actually up to the patient to think about with a doctor ways that they can improve their overall quality of life. And so that would be thinking about nutrition. Is there a certain way that they can tune up their diet to feel better in that regard? Exercise, which is very good for MS patients. We've seen that in multiple studies. Sleep is important, so people should try to get at least 7 or 8 hours of sleep. Emotional stability, which is really important when somebody's dealing with MS. And so trying to work with programs or other ways to try to build up their emotional stability and resilience. And then I always say it's really important to try to have fun too. So to think about the ways that somebody can increase that in their life. MSAA is a wonderful organization where patients can go to help deal with their challenges that they have with MS. There is a helpline that patients can call to get more information. There's wonderful cooling and equipment programs that patients can use. There is MRI funding assistance and also educational programs that are across the country. There are also online resources which are very helpful. That includes a mobile phone app called My MS Manager that is available both in Android and iOS, and that helps patients track disease activity, store their medical information, and then also generate charts and reports for various metrics. That can be very helpful. There's an excellent website, and there's also a new online peer community where patients can go together and share their experiences. I often tell my patients to go to their website at mymsaa.org to learn more.